I'm just going to have a quick look directly from this morning's PAC report, where it says that NHS England acknowledged that there would have been more investment and progress in enhancing community services in 23-24 had it not been obliged to redirect funding to prop up day-to-day spending in NHS systems. Is the problem with getting rid of ring fences not that we just end up fixing and keeping going the systems that are already not really adequate?
I think the thing about ring fences, as we've sort of discussed already, is actually a bit complicated. So I apologise if I've sounded like I'm too black and white on. I'm really not. I think Julian's made the point that where there are specific things that we really can see the benefit of, there is a strong case for ring fences. Equally, if we're really going to trust local leaders and move to a more devolved model, we have to untie their hands on some of this. But the pressures of the acute spend have meant that there has been, in particular, I think some of the things that they would have wanted to do, and you'll speak to them directly on prevention, on other things, have been harder to find the funding to do because they've ended up having to prop up acute funding. That is why I think unapologetically we have been focusing on acute productivity over the past couple of years and continue to do so, as well as all of the things I've described and we've talked about in this committee so far about how we then support our acute colleagues, and I was one, ran an acute and community trust until a few years ago, to make sure that they have the tools to deliver, which are particularly about things like technology, estates, etc.
Because I've asked about left shift and you've told me about acute services, which is very much not what, not the shift that we need to see. And I appreciate we need to have the ongoing funding for left shift, but actually that doesn't indicate to me that there's a shift in resources. If you look at the prevention question, which is one of the other shifts, one of the points that's made in the PAC report is that the public health grant is going down, and it says very specifically there needs to be a shift in NHS culture and resources towards prevention. So what are we doing? And again, I don't want to hear that there's more money needed in acute services, because I appreciate that money is needed in acute services because the prevention is not being done. But what are we doing to shift NHS culture and resources, as we're going to have to do with a less public health grant, to prevention and to both community and prevention?
My apologies. I thought your question was how do we stop acute services taking up more of their share of the budget? So that's why I was giving you the answer about productivity in acutes and what we were doing to try and make sure that there was that wasn't the case in the future. In terms of I think what you are saying, which is, so what are we doing then on the community shift? So some of the things we've done over the past couple of years have really been about making sure that, particularly as far as general practice is concerned, that has been about the technology investment in things like cloud-based telephony, in the ability to then put triage systems in place in workforce. So we've got all of the increase in R's roles, and now specifically the funding has gone in for up to 1,000 additional GPs this year. We've got additional funding going in for premises this year as well, to try and recognise it's a huge amount of work to do. This is not a magic bullet, but it just begins the journey. All of these building blocks that we've been investing in over the past years, and it, in this sense, that the investment bit just means people. So it means people and tech being able to then now be in a position where we can start to join that up to begin to form something that looks much more like that neighbourhood health model. Some of the secondary prevention work, which again I think we would all acknowledge did take a particular hit in COVID, but now it's partly incentivised through the contract, but it's partly one of the things that we're looking at contract reform to help go further, particularly CVD, particularly diabetes, which speaks to the secondary prevention point.
You talked about how we're kind of shifting things to GP, getting more efficient, better services there. Have you done any evaluation on how GP telephone triage is working?
So we're working at the moment with PCN pilots. So we've got PCN pilots that we're working with at the moment, and they are really exploring with us. It's a whole heap of things. So it includes things like telephone, how the telephone cloud-based telephony is working. So they're sharing all their data with us on volume of calls, speed of response, number of drop calls, all of that data. They're also sharing with us their experience of triage, really different systems in place across
how are you evaluating that data?
Yeah, so that's ongoing at the moment, but it's a partnership approach between those PCNs and NHS England, where it's a real open book arrangement. I met with some of them, I think
Can you give us a timeline on when you'd be evaluating that?
They're doing, when's the final report? I'll have to write back to you on when we'll get a final report. We're doing audit weeks once a month at the moment. It's real open book sharing, because we're also looking at the financial sustainability of practices and what it really takes to make sure that I think we all share the same ambition, which is to have a really thriving, sustainable primary care service at the heart of a neighbourhood health model. So this is the detailed work that we're doing with those partners to try and make sure that we really have understood the impact of some of those initiatives, and then we can course correct if they're not working in the way that we would want them to, or they would want them to.